Good afternoon. Thank you for joining us today for End-of-Life Decisions for Individuals with Intellectual and Developmental Disabilities and Dementia. My name is Ashley Haas, and I'm the Director for Consumer Information at the Benjamin Rose Institute on Aging. This session today is being offered as part of the Administration for Community Living, Alzheimer's Disease Programs Initiative Project, expansion of dementia-capable communities within urban and rural settings in Ohio, using evidence-based and informed programming. Today's webinar will be recorded. During the webinar, you may submit a question at any time using the Q&A button at the bottom of your screen. We have staff monitoring the questions in the chat to convey your questions to our presenter and to answer any technical questions you may have. And you can turn on captions by selecting live transcript, which is the button with 2 C's at the bottom of your screen. We are conducting an evaluation of our dementia education sessions as part of this project. You should have received an email with a link to the pre-session evaluation questionnaire, which also contains further information about the evaluation. If you did not have a chance to complete the pre-session questionnaire, we ask that you please complete this now using the link provided in the chat. By doing so, you are helping others in your community. Your responses and feedback will be used to show the impact of programs like these and to improve the tools and resources provided to individuals living with dementia and the people who support them. I now have the pleasure of introducing our speaker for this afternoon's presentation, Ms. Sally Tomko. Ms. Tomko has over 38 years of experience. She has practiced in the ICU and ER and as a business development specialist for a large physician practice, home care, and hospice agencies. Currently, Ms. Tomko is a provider relations manager for Hospice of the Western Reserve, serving on their Dementia Collaborative Committee on Cleveland's West Side. Please join me in welcoming Ms. Sally Tomko.
Hi, thank you so much. Appreciate this, Ashley. Appreciate the introduction. And thank you, Benjamin Rose Institute on Aging. So today I'll be speaking on acknowledging end-of-life decisions and choices for individuals with IDD, ASD, and dementia. I'm going to share my screen. And Ashley, if at one point you could just unmute and let me know that you can see everything okay, that would be wonderful.
Yes, it's coming up very well.
Okay. I'm trying to get the slides to come up here. The top won't move. I'm not being able to advance. Ashley, I can't get the bar off of the very top, so I can't hit share slides.
Okay. Could you reduce it on the right-hand side? Oh, sorry, the one right next to it.
Glad somebody knows what they're doing from a technology standpoint. Great. Can you see it all right?
Yes, we're all set.
Wonderful. Thank you so much. Well, people with developmental disabilities are now aging. The benefit of long life is undoubtedly to be celebrated. And this includes respect for their wishes about healthcare interventions and where they want to spend their last days, as well as maintaining emotional attachments to the people that matter in their lives. The aging of people with intellectual disabilities, IDD, autism, and dementia presents challenges for systems to be able to provide appropriate supports for end of life and to ensure that the dignities, rights, choices, and humanity of disabled people are fully included and respected. At Hospice of the Western Reserve, we pride ourselves in offering equality, diversity to a wide range of individuals, and that's inclusive of people with IDD, autism, and dementia. All people, regardless of their diagnosis, are indeed people first. So these are the objectives I'll be covering today. I'll be differentiating between intellectual disabilities and developmental disabilities, identifying barriers to recognize end of life in people with IDD, autism and dementia, identify the needs of adults with IDD, ASD, and dementia. I'll be discussing tips for healthcare professionals in end-of-life discussions and recognize the importance of advanced care planning with individuals within this population. Intellectual disability, or IDD, and ASD, which is autism spectrum disorder, are the most common developmental disorders present in humans. Combined, they affect about 3 to 5% of the population. And then additionally, they can be found together in the same individual, thereby complicating treatment and end-of-life issues. Doctors often mistake one condition for the other, and sometimes they might just diagnose one. There can be a genetic overlap, however, that might blur the picture. And most genes that are identified as autism genes can also cause intellectual disabilities. So how common are intellectual and autistic developmental disabilities? Well, approximately 6.5 million people in the US have an intellectual disability. And about 1 to 3% of the global population has intellectual disability. So that means that as many as 200 million people. The number of 8-year-old children diagnosed with autism spectrum disorders is now 1 in 54 live births. And I remember my daughter, who will be turning 23 next year, when she was born in 1999, that number was 1 in 250. And now it's 1 in 54. So why are we seeing that number rise with ASD? Could it be attributed possibly to a true increase in the risk of developing it? Or is it just solely that changes in community awareness, healthcare professionals' awareness, and the diagnosis? There's not an answer to that, but just something to think about. So what are intellectual and developmental disabilities? Well, intellectual disabilities start any time before a child turns 18, and it's characterized by problems with intellectual functioning or intelligence. And this can include the ability to learn, reason, problem solve, and other skills. There's also issues with adaptive behavior, and that includes everyday social and life skills. On the contrary, developmental disabilities is a broader category of often lifelong disabilities that can be intellectual, physical, or both. IDD is the term that is often used to describe situations in which intellectual disabilities or other disabilities are present. So there's been some demographic changes. 75% of people with IDD live with their families, and 25% of family caregivers are over the age of 60. So for the first time in human history, persons with developmental disabilities are now outliving their parents, who have historically always functioned as their primary caregivers. And this is according to Jeffrey Mind, who writes The Graying of the Disabled America. So let's look at IDDs and body function. The first would be the nervous system. And with the nervous system, these disorders, they affect the brain, the spinal cord, the nervous system function. And then in turn, that can affect intelligence and learning. These conditions can also cause other problems, such as behavioral disorders, speech or language disabilities or difficulties, seizures, and trouble with movement. Another body function that is affected is the sensory system. So seeing, hearing, touching, tasting, smell. It affects how the brain interprets that information. And it's also affected from a metabolism standpoint. So it affects metabolism and how it processes, how the body uses food and other materials for energy and growth. For example, how the body breaks down food is considered the metabolic process. And problems with the metabolic process can upset the balance of materials available for the body to properly function. PKU or phenylketonuria is just one example of a metabolic condition that can lead to IDD. So let's look at some types of cognitive impairment. There's mild intellectual disability, moderate, severe, and profound. And the degree of the impairment varies very widely. And there's less emphasis on the degree of impairment. For example, the use of IQ measurements, and more on the amount of what types of interventions are needed for that individual. IQ scores are very relevant. They are needed and important in assessing, but mental health professionals have to consider a person's individual abilities and impairments across skill areas such as conceptual, social, and practical life skills. So I'm just going to do a little overview here on some of these intellectual disabilities. So if we look at mild intellectual disability, we see, and of course that's not the only measurement, but we normally see that IQ of 50 to 70. They're slower than typical in developmental areas. There's no unusual physical characteristics. And these individuals are able to learn practical life skills. There's an attainment of reading and math skills up to about grades 3 through 6, and an ability to blend in socially, and again, able to function in daily life. So with mild intellectual disability, about 85% fall into this category of the mild category and may even achieve academic success. A person who can read but has difficulty comprehending what he or she reads represents one example of someone with mild intellectual disability. So now let's look at moderate intellectual disability. And again, we're looking at that IQ of 35 to 49, not the only skill that we look at. We start to see some noticeable developmental delays with speech and motor skills. There may be some physical signs of impairment, such as a thickened tongue, and they're able to communicate in basic and simple ways. In addition, they're able to learn basic health and safety skills. They can complete self-care activities and can travel alone to nearby and familiar places. So most people with moderate intellectual disability have fair communication skills, but they can't typically communicate on a complex level. They may have difficulty in social situations and maybe issues understanding social cues or even making judgment decisions. They can care for themselves, but might need more instruction and maybe support from another individual. Many can live in independent situations, but still possibly may need the support of a group home. About 10% of all individuals with IDD fall into this moderate category. So now let's look at severe intellectual disability, and that's the IQ between 20 and 34. There's considerable delays in development. There's an understanding of speech, but little ability to communicate. They're able to learn daily routines and also able to learn very simple self-care. There is direct supervision that is needed, particularly in social situations. Only about 3 to 4% of people diagnosed with IDD fall into the severe category. They can't perform all the self-care activities, and as I said, they might need some direct supervision. They can't necessarily successfully live an independent life and need to live in the group home. And lastly, profound intellectual disability, and that is an IQ of less than 20. We will see significant developmental delays in all areas. There's obvious physical and congenital abnormalities. There's a requirement of close supervision, and they often require the attendant to help in self-care activities. They may possibly be able to respond to physical and social activities, but not capable of independent living. And with this category of IDD, about 1 to 2% of individuals fall into this category of profound. So let's look at people with IDD in the aging process. They're living longer. Systems and services are underprepared to assist them with the aging process. Remember, I spoke early in the earlier frame, they're outliving their parents. Back in the 1940s, someone with IDD, the life expectancy was about 20 plus years. And by the 1960s, that improved to about age 30. And today, the average life of 65 years compared to 70 in the general population. So you can see where that's balancing out and how that's occurring, that they're outliving their caregivers or their parents. And by the year 2030, age 60 and over is projected to reach 1.2 million people. Much of this increase in the long life expectancy is due to improved healthcare, social services, recreation and physical activities, good nutrition, personal and spiritual education, and employment opportunities. And like other adults, people with IDD, the women live longer. And for those affected with IDD with the combination of Down syndrome, they average where they pass usually about 10 years earlier at about age 56. So let's look at aging persons with IDD and dementia, because there can be a crossover. Someone with IDD later in life can develop dementia. But the key difference between dementia and IDD is the loss of a person's typical level of functioning or their baseline. And it's really important to define that baseline. Children and adults with IDD are getting better support. And as I said, they're living fuller lives. So there's that possibility, because of that increase in age, that they may possibly develop dementia. And that's a condition marked by a loss of intellectual skills and abilities. While it's important not to assume that a person with IDD has dementia simply because they're getting older, and it's equally important that symptoms of dementia are not missed because they're mistakenly seen many times as a part of that person's disability. An accurate diagnosis of dementia poses a unique challenge for individuals with IDD. And many of the characteristics between IDD and dementia are similar. In a case of Alzheimer's and Down syndrome, there might also be a genetic link with dementia that they have found. And while some characteristics of dementia and IDD may look the same side by side, it's the loss of an individual's baseline abilities that can point to the dementia. Again, we need to know a person's baseline because that is the most reliable way to identify changes that could point to dementia. And you can create a baseline for a loved one or someone you're caring for informally, just by taking notes and noting their basic self-care skills, their communication, their talents, skills, daily activities, and hobbies through adulthood. So you can put that down, record that, write that on paper, and that's going to trigger your baseline. And if you start to see those changes as that person's getting older, there could be that dementia connection as well. So what are some common signs of dementia in a person with IDD? We'll see confusion and problems with recent memory, wandering or getting lost in a familiar place, moving with rapid shuffling steps. There may be loss of bladder or bowel control, laughing or crying inappropriately as opposed to their baseline, difficulty following instructions, loss of speech, disorientation, a loss of daily living skills, changes in personality, long periods of inactivity or apathy, and perhaps the development of seizures. Now, all of these signs also might indicate a medical or a mental health condition. So even if you're seeing these signs and thinking, wow, these are common signs of dementia in this person with IDD, that physical illness or other causes need to be ruled out And examples of those would be depression, stress, loss, or even a change in development in environment. If you suspect the change in the person's baseline abilities are due to dementia and not other causes, it's most important to consult with a physician for an evaluation. So what are some barriers to recognizing end of life in persons with IDD and autism and dementia? There's greater health needs than that of the general population. People with IDD don't always know when they're ill or when to see a doctor. And I keep referencing IDD, but it's collaborative. Those with IDD, autism, dementia, they don't know that they feel sick many times. They don't know when to see a doctor. They may not be able to tell that they feel unwell or that they feel different. Most times it's the families or support staff or healthcare professionals that'll notice the changes in behavior and notice that someone's not feeling well and maybe make that appointment with the doctor. There's things to look for, such as swellings or lumps, changes in toileting habits, changes in eating habits, generally feeling unwell. Maybe they're tired or lethargic. There might be some changes in behavior or an uptick in behaviors. Weight losses and gains. Maybe they're asking for pain relief more often than they were before. And all of those providing support, we all need to work together to improve on early recognition that there's these changes going on with this individual away from their baseline. And that could be the beginning of end of life. There's also diagnostic overshadowing. I'm not sure if anyone has heard of that, but it's a common theme in disabilities. And what that is the label that that person has, IDD, autism, dementia, it overshadows other physical health problems. So if someone's taken to the ER, maybe seeing a doctor or the nurse, they focus on that person's label, and then they're not seeing the fact that that person has drastically changed from their baseline and maybe starting to enter end of life. Evidence has found experiences of individuals hitting the crises, such as an emergency room, admission to the hospital, before any recognition was given to the changes in that individual. So we're seeing those changes, but could it be end of life changes? Well, we're going to see a decrease in that usual baseline, a deterioration in usual ability or with activities of daily living. Comorbidity is regarded as the biggest predictive indicator of mortality and morbidity. There's that general physical decline. A progressive weight loss is often an indicator. Maybe there's, as I mentioned, those repeated unplanned crisis admissions or ER visits. Maybe the individual is receiving treatments and they're starting to decrease a response to the treatments. And many times when we look at blood work, we start to see a decrease in the serum albumin. And that's because that'll indicate muscle wasting or muscle loss in that individual. So we want to look at patient-centered end-of-life planning. And making choices and decisions is important to all people during end of life, including those with intellectual, developmental disabilities, autism, and dementia. Person-centered planning is the way of helping people to think about what they want now and what they want in the future. So at end of life, what are the needs of adults with IDD, ASD, and dementia? There's physical needs. There's symptom control and management. And concerns about physical comfort and symptom management at end of life was reported by adults in a number of studies. To achieve good symptom management, we need to know that person's habits, their behaviors, and then we can approach them from a centered approach. There's also medical decision making. Medical doctors state that more involvement with adults with IDD, dementia, and autism is needed in discussing end-of-life issues. There needs to be regular meetings, identifying clear roles and responsibilities for everyone involved with that person. There's also emotional needs. Adults with IDD, many times they feel they're invisible. It's suggested that if emotional well-being is to be promoted, it needs to be strongly linked with clear communication and a plan that encourages dialogue with the adult, the family, and the healthcare professionals that are involved in providing support for that individual. It's challenging though, and there's issues related to protecting adults from difficult decisions and not disclosing information. And this was rated as a significant concern for people with IDD, autism, and dementia, and that can lead to emotional distress. There's also social needs, communication. Every single person has different needs and issues related to the disclosure of a diagnosis and prognosis. The challenge of families and healthcare professionals is protecting adults. And that raises the issue of non-disclosure of a diagnosis or prognosis. This is seen to occur for a variety of reasons. Maybe we want to prevent stress for that individual. Maybe it's too difficult for us to be the bearer of bad news, or that the bearer of the bad news lacks the emotional capability or knowledge or skills to disclose information. Further challenges can also add to the complexity of disclosure, such as that individual person, maybe they don't have that ability to understand. Maybe there's a lack of sense of time on the part of that adult, and possibly conflicting views. It's recognized that adults have a right to know their diagnosis and prognosis, and that this knowledge helps the person cope and prepare for end of life. We need to involve adults with their last wishes. We need to know what their last wishes are. They need to be known. There's also rights and choices. So in addition to the right to know and make decisions, the right to choose the location of death is very important to those with IDD, autism, and dementia. And findings reported by a Canadian study suggest that more collaborative work between disability and end-of-life services are needed to provide inclusive end-of-life care. And this is central and needs to be achieved. There's also physical needs. There's an absence of specific references in literature to the spiritual needs of adults with IDD, autism, and dementia. Little evidence was found for those in having those conversations about end of life and death and dying. The challenges for staff when discussing issues such as final wishes, rituals, and remembrance were noted as being complex and requires healthcare professionals to have specific training. For adults with ID, supportive rituals relating to end of life, they can be so therapeutic and promote understanding. And therefore, when appropriate, they should be explored and they should be encouraged. So advanced care planning, who decides? Clinicians should elicit individual preferences regarding end of life for adults with IDD, autism, and dementia. And many times, as we know, because of the trajectory, sometimes specifically with dementia, this needs to occur early on when the person is initially diagnosed with dementia. Early discussion of a disease likely course, as well as concerns such as cardiopulmonary resuscitation, mechanical ventilation, artificial nutrition, spiritual values, and place and circumstance of death is helpful. But who decides? Many patients have legal guardians, and often, but not only, sometimes and not all the time, there's family members involved. And these are the people that have the decision-making responsibility. But for those with IDD, autism, and dementia, they want to and they deserve the right to be able to express their values and wishes, and we need to accommodate them. Non-guardian family members and caregivers often provide valuable insight into what a person's wishes may be, and we can include this in the planning process for end of life. So now let's look at some tips for healthcare professionals and when we're having these discussions. We want to ensure that the person is involved in decisions about their care, not just the family, not just the guardian, but the person themselves. But keep in mind that that person may have different communication preferences or skills and ways of processing communication and information. So we need to make sure that we're presenting that information and choices to them so that they can understand and have a significant impact. Capacity to make decisions. And of course, as I mentioned before, it depends on where someone is on their trajectory, specifically with dementia. And if an individual doesn't have capacity, meaning they cannot understand to help let us know their wishes or share what they would like, if they don't have that capacity, then every effort should be made to determine their wishes. Maybe there's a family member they've discussed it with years ago and what they would like to see at end of life. There needs to be a strong partnership between healthcare teams, and that's essential. So regular discussion forums, meetings, team meetings, providing supportive spaces for everyone involved in that patient's care to be able to discuss end of life. There needs to be understanding and the thinking style of the person you're supporting. How does that person learn? How do they think about? How do they understand the world around them? How do they learn? How do they take in new information? We need to know these things before we're having these discussions. We want to make sure we support the person to reflect on important events in their life and experiences that have given their life meaning. And these reflections, they could be reflections through video, through audio, sense, textures. And so many times we can use those things in having these end of life discussions to be able to understand what their wishes are. There's a real importance of communication assessment and monitoring tools. So just a couple quick tips here. Sitting face to face with that individual in good lighting. We want to be alert to attempts of nonverbal communication. So maybe the eye contact or facial expression that that person is giving us. Sometimes that facial expression or eye contact can let us know that they're having that understanding. If you don't understand what someone is saying, ask them to say it again more slowly or try to say it in another way. Find out about that person before that discussion. What did their normal day look like? What sorts of activities are important to them? What disturbs them? We can make recommendations during these conversations to your best ability of how you understand that person's wishes, but we can't just guess. We need to pull everything together, including the history of their life, to know how possibly they may want to spend their lasting days. If an individual uses sign language, of course, we want to make sure that someone is going to be able to be there to sign with them. Many times we want to involve a communication partner, that person who knows that person well, and they can mend any communication breakdown that could occur. We want to have good communication using these tools, because effective communication is the key importance at the end of life. Many people with IDD, autism, and dementia have significant difficulties in communication. with both expressing themselves and understanding what people are saying to them. So we need to strategize to be able to support them, to be able to have optimum communication at times that are critical, and especially at end-of-life planning. We want to make sure we're supporting speech and written information with visuals, again, photographs, pictures, symbols. If an individual has a communication book, bring it along. We want to make sure that we're not speaking too quickly and using short, simple sentences. We want to avoid complex or abstract vocabulary and explain any new information. Be sure when you're having these conversations to assess for understanding by asking them to tell you what you have said and not simply asking, do you understand? We need to hear it back from them that they understand, maybe repeating what you had said back to you. Then you'll know that they have some understanding. And of course, with any meeting and with healthcare and decisions, we want to make sure we're allowing for plenty of time for an individual to process information. There's a need for support and accommodations from diagnosis to end of life that are person-centered and inclusive to the diversity of the needs in a broad spectrum of individuals. Many times there's difficulty assessing equitable and appropriate health care. There's social and communication understanding difficulties that may affect how they form and sustain a network of social support. There may be differing perspectives and thinking styles that may affect the way they understand their illness and how they express how they feel. A definition of meaning and spirituality that may be deeply personal. And these individuals might be struggling to place themselves in the narrative in their life. We need that strong link between healthcare, social services, family caregivers, guardians, to be able to provide holistic end-of-life care that encompasses and develops the understanding of that person's individual needs and wishes. There needs to be that acknowledgement, that peace at the end of life comes not just from medical intervention and not just from symptom control, but from an understanding of who we are and what is important in life. Next, I'm going to play a video. It's called Thinking Ahead, My Way, My Choice. It will run about 8 to 9 minutes in length. And this Thinking Ahead, My Work, My Life, there's actually workbooks that go along with this. And this was created by California advocates with developmental disabilities, and they wanted to share their experiences and their ideas about making end-of-life decisions. And the video was made possible by a wellness grant through the California Department of Developmental Services. The reason I have included this video, because it takes the perspective specifically from their own eyes and their own words. And I think that there's a lot that we can gain from that, and maybe tools that we can use as caregivers and healthcare professionals when we have these discussions.
Thinking ahead, my way, my choice, my life at the end. Hello, my name is David Lopez. I am the narrator of this DVD. You know and I know that living your life your way means making important decisions for yourself today and in the future. It also means thinking ahead to make decisions about what you want at the end of your life. Talking about death and dying is not easy, but being prepared for that time assures your choices are known and protected. This DVD and the Thinking Ahead workbook will help you think, plan, and do what you need to be prepared. Thinking Ahead, my way, my choice, my life at the end. In this DVD, Eugenia shows how she used think, plan, do to complete her Thinking Ahead workbook to make a plan for her end-of-life choices. She knew that with a plan, she would be prepared, in control, and able to take action for herself. Think. Eugenia began her own plan by thinking about a person to help her complete the workbook. This person is called a trusted helper. Her trusted helper would be someone who knows her well and cares about her, can help her complete the workbook, but not tell her what they think she should do. Plan. Eugenia decided to ask her friend Kathy to be her trusted helper. Eugenia talked to Kathy about listening and respecting her choices. Kathy signed Eugenia's workbook, agreeing to help her think carefully and make her own end-of-life plan. Do. Eugenia and Kathy started by going through the workbook before writing down any of her choices. Think. Eugenia knew that near the end of people's lives, they make choices about the place where they want to spend their final days. She took time to think about where she wanted to be, how she would be cared for, where her personal things would go, and what her funeral and burial would be like. Plan. With Kathy's help, Eugenia began to make her personal plan by thinking about these questions and putting her choices on the workbook pages. Eugenia made her choice about where she wanted to be in her final days. She decided how she wanted to be cared for, like having her favorite people around and what would help her feel comfortable. Eugenia decided where her personal belongings and her dog would go. She also wanted to leave a special gift to her friend Tammy. Eugenia also decided how she wanted to be remembered. Do. After making her choices, Eugenia filled out the personal request form at the back of the workbook. She made copies of the completed form and gave them to important people in her life so they would know her wishes. Think. Next, Eugenia thought carefully about what medical treatment she wanted in her final days. She also wanted her doctor to know her decisions. It helped Eugenia think about the kind of life she wanted at the very end, sometimes called quality of life, when making choices about life support treatment. Plan. Life support treatments are used to try to keep people alive when they are very sick and close to death. Eugenia, with Kathy's support, began a personal plan by these questions and putting her choices on the workbook pages. Do life support treatments. Eugenia filled out the advance directive form at the back of the workbook. The advance directive form will tell her doctor what her choices are. Think. Eugenia learned it is important to have an end-of-life advocate, also called a health care agent. This person would speak for Eugenia if she were too sick to speak for herself about medical treatment. Eugenia's end-of-life advocate would be her legal spokesperson, be someone nearby to make sure her advance directive would be followed. Plan. Eugenia decided to ask Claudia, another person she knew and trusted, to be her end-of-life advocate. Claudia agreed to take on this important job. So Eugenia put down Claudia's name in her workbook as her end-of-life advocate. Do. Eugenia took action by making sure her advance directive form at the back of the workbook was completed. She and Kathy made sure she followed the directions and had 2 witnesses sign her completed advance directive. Eugenia tore off the completed advance directive form and made a copy for her end-of-life advocate. She also gave copies to other important people, including her social worker and doctor. Now Eugenia is prepared and has a plan to share with other people. This DVD and the Thinking Ahead workbook were developed through a wellness grant from the California Department of Developmental Services. Thank you to the many advocates who participated in the focus groups to share their thoughts and feelings about the importance of being in control throughout their lives. Special thanks to Alta California, Golden Gate, and Eastern Los Angeles regional centers.
So as you can see, as he mentioned, that those workbooks and that DVD are definitely available. And then we also have a workbook here at Hospice of the Western Reserve that really is kind of a tutorial and takes you through the steps in making those decisions and can help with that planning with the end-of-life decisions. So in conclusion, at end of life, adults with IDD, autism and dementia, have many similar needs to the general population. The need exists for good physical care, effective symptom management, and clear communication. In addition, the presence of family and healthcare professionals who can provide emotional and spiritual support ensures that adults with IDD, autism, and dementia can meet their end-of-life goals. The specific challenges that can occur include those relating to capacity, lack of choice, of location of care, and lack of disclosure can be challenging. But these needs are not exclusive to this community. If the principles of person-centered care are carried through to end of life, the physical, emotional, social, and spiritual needs of adults can be met, thus providing the adults with dignity and compassion at end of life and ensuring that a good death is achieved. sure if there's any questions or the time for questions. I don't see anything that's typed in during this. Stop sharing there.
Thank you, Sally. So we do have time for a few questions. We really enjoyed your expertise and your insight. We did have a few questions come through, but we just wanted to remind everyone to submit your questions using the questions box in the control panel on the right-hand side of the screen. So someone wanted to know if you could just provide them with the information on how they could get the workbook and the DVD from the video that you showed everyone.
Okay, let me hang on one second here. So if you Google Thinking Ahead, My Way, My Choice, My Life at the End, if you just put that into a Google and then put DVD or workbook, it'll come right up when you Google that. And it's, as they said, through the California Department of Developmental Disabilities who had put that out. And it's a little different. So do know that their advanced directives in California are different than ours. There's different forms. For Ohio, we have them here. I'm not sure if there's any people on from any other states, but make sure that you're following the proper advanced directives for the state that you're in.
Thank you. And we appreciate that clarification as well for those who are joining us from other states. Someone did also want to know how they should approach healthcare professionals if they think that their loved one is not getting the care that they think that they need because of the diagnosis overshadowing that you had mentioned earlier in your presentation.
Okay, and I'm not sure which health professional that they're thinking of. It could be that individuals in a group home, and maybe the individuals in that group home are not picking up on cues or physical characteristics that that person may be entering end of life. So that would incorporate, you know, some education and just yourself, arming yourself with that education, especially that baseline. So maybe it's a nurse or a nurse practitioner or a physician, and you think that that diagnostic overshadowing is occurring. Have that documentation and say, you know what, this has always been my loved one's baseline as far as eating, bathing, toileting, communication, and it's changed drastically in the last 3 months, 6 months, 1 year. And so I feel that maybe there's decline happening here, and maybe we're starting to enter some of the stages of end of life. But being able to have that, you know, from the baseline, and you can record, you can, I mean, that baseline doesn't have to be at the beginning of diagnosis. You can start that today in taking that baseline.
Thank you. That's a very important reminder for everyone. We do have some questions that we aren't going to get to, so we will put those together at the end of the chat and email those participants those questions. As a reminder, we will be sending out the recording of the presentation as well as the PowerPoints that were used in the presentation. Before we conclude today, though, we would like to have our project director, Branka Prometica. She's going to tell you briefly about BRI Care Consultation. It's a care coaching program that's available for families who are impacted by dementia in various counties in Ohio through the Administration for Community Living Project. Branka?
Thank you so much, Ashley. I'm going to share my slides, and I'm having the same happen with my slides. So hold on 1 second. Okay. Thank you again, Sally, for a wonderful presentation. For everyone who is on the as attendee today, we really appreciate your time. You know, this project is generously funded by the Administration for Community Living. And in addition to the educational session that you had just listened to, we also have a program that is available for those of you to connect yourself or anyone that you know that could benefit from a telephone and email-based care coaching program. Now, this program is in terms of eligibility criteria, it's those with or at risk for dementia. And at risk is the key term. So the person does not have to have dementia. They could be at risk. And this program also serves persons with intellectual and developmental disabilities, and of course, supporting caregivers. It's available at no cost, again, generously funded by the Administration on Community Living. And just to dive a little bit deeper in what the program does, so a personal care consultant is assigned to each individual or family. And this care consultant really helps with finding and getting connected to different types of services, getting to know what the services offer, and then also listening to the concerns and helping to prioritize by creating a step-by-step plan that's really unique to that individual and family. A lot of times the care consultant facilitates a conversation and helps with communication with loved ones and getting others on board, how to handle some changes and maybe some behaviors that are not as easy to manage. Also staying in touch is a key area. This is not a one-time information and referral source. Anyone that enrolls this program continues to receive the services for an extended period of time. Again, assisting with getting others involved. And lastly, just serving as an emotional support for those caregivers that are going through difficult challenges, especially with end of life. And so I know a lot of our care consultants do refer to the Hospice of the Western Reserve, of course, with their expertise. The care consultants also help with connecting to other services. So really bringing those key players to help with the situation. Now, how do you get connected to this program? Well, here we have in our area of the northern part of Ohio, as well as some rural areas, the program is available. So we have the counties listed: Cuyahoga, Lake, Geauga, Lorain, and Medina counties for those with or at risk for dementia. Their families is offered by We Care through the Benjamin Rose Institute on Aging. Also, for those with intellectual and developmental disabilities, you can get connected to Welcome House in the area as well. And then we have O'Neill Center serving Washington County, as well as Wood and Pleasant in the West Virginia area, and then United Seniors of Athens County in Athens, Ohio. So I know that there's attendees from a variety of different areas throughout Ohio and throughout the country. As far as this project, it is focused on these key areas. But again, we appreciate your time. Back to you, Ashley.
Thank you, Branka. We do want to thank you again for joining us today, and we especially want to thank our presenter again, Ms. Sally Tomko, for such a wonderful presentation of end-of-life decisions with individuals with IDD and dementia. As I mentioned, a recording of today's session will be made available at www.benrose.org on the event registration page and in our resource library. We are offering more webinars like this for community organizations and for families impacted by dementia each quarter of this ACL project. We hope that you will join us for our upcoming webinar on November 30th from 12 to 1, titled Preventing Caregiver Burnout, Creating Your Self-Care Plan. To stay up to date about all of our webinars, please visit our website. Again, that's www.benrose.org. In the chat, you will see a link to a post-session questionnaire. You will be receiving it via email later today as well. We ask that you please complete the post-session questionnaire within 1 week following today's session. Your responses and feedback will be used to show the impact of programs like these and to improve the tools and resources provided to individuals living with dementia and to the people who support them. Again, thank you for joining us today, and we hope you have a great rest of your day.